It's my pleasure to introduce Dr. Paul Pottinger. He and I know each other both professionally, but also really more so our children have gone to school together since they were in kindergarten. And they're now 14 years old and very interesting creatures. Wonderful and interesting. But with that in mind, he's the Associate Professor in Infectious Disease and in the division's Clinician Educator Pathway, Associate Director of the ID Training Program here, and he focuses on optimizing training experience for first-year ID fellows. I want to just take that moment and comment on how important our clinician educators are. They are here to educate you. They're here to educate our next generation of medical students and residents and fellows in their areas of expertise, and really requires an incredible amount of mentoring and role modeling, and it really takes an exceptional personality to be a really good clinician educator. He directs the Antimicrobial Stewardship Program at the UW Medicine, and its aim is to improve the use of anti-infective medications for complex and heterogeneous patient populations. This is him in the lab, directs the UW MC Tropical, well actually not in the lab, he's like cleaning stuff maybe. The Tropical Medicine and General ID Clinic brings his fellows there into contact with patients that are going abroad and treated for a large variety of infectious disease. He's an attending physician on our inpatient unit for the ID consult service for solid organ transplantation. I think, as you guys know, people who have organ transplantation are highly immunosuppressed, and so exposures to infections, acquisition of infections require an enormous amount of expertise to manage their infections. And thus, the Seattle Cancer Care Alliance consult service and also the General Internal Medicine Ward. He travels a lot, I know that. And here he's at High Camp this is in Mount Vincent in Antarctica. So he collaborates with colleagues at the UW, Johns Hopkins, and London School of Hygiene and Tropical Medicine. And as you can see, he really does travel all over the place. Earned his medical degree at Yale and completed his residency and internship at University of Colorado Health Sciences Center in Denver. Received his diploma in tropical medicine and hygiene from London School of Hygiene, Tropical Medicine in Bloomsbury, England. So with that in mind, it's my pleasure to introduce Dr. Pottinger.
Thank you. Thank you so much. So much fun. Thanks to all of you for coming out to talk about bugs. Mini medical school. How cool is that? I wish they had that back in the day, although I loved my 4 years of medical school. Almost always loved my 4 years of medical school. So folks, we've heard from Dr. Lynch about the global perspective on antimicrobial resistance. We've heard from Dr. Cookson about efforts right here at UW Medicine to bring more accurate, timely diagnostics to the bedside. And I want to bring this home to you, each and every one of you. And then we'll take your questions. But I've got a question for you. So a show of hands, who in the room has ever consumed antibiotics? Okay, and those of you not raising your hand, I know you don't eat meat because otherwise you would have eaten antibiotics too. So everyone in the room's hand went up. Now, question number 2, who here today is here because of antibiotics? Whose life was saved by that particular treatment? 1, 2, 3, 4, 5, 6. There are 9, maybe 10 in the back. So that's about right. I've asked this question of audiences coast to coast, around the world. The answer is the same, no matter where I go. We've all had antibiotics, nobody more than me. As a 6-year-old kid with all my middle ear infections, I can still taste the bubblegum flavor of that amoxicillin. And yet, only a few of us actually relied on those drugs to save our lives. So this is it, in a nutshell. How do we balance the drug use that makes our lives better? I've never had a UTI, but it sounds awful. I'd want to be treated for that. Versus the drug use that will keep us going. Sepsis. I'd be so keen to talk with those of you whose hands went up. Did you have meningitis? Did you have bloodstream infection? Did you have a wound infection that was threatening life and limb? This, in a nutshell, is antimicrobial stewardship. So here's a review from Dr. Lynch's lecture. Yep, it's pop quiz time. Let's say it together. What proportion of antibiotics are given to Homo sapiens in the United States? Damn right, you guys are sharp. 20%, very good. The rest go to non-human vertebrate animals. And that translates to roughly how many courses of antibiotics per year in the United States? You didn't exactly tell them this. About one for every person. There are about 300 million antibiotic prescriptions in America. Some of us don't take them in a year, some of us take many courses. It comes out to about one for every man, woman, and child. Now, what about inpatient versus outpatient? Inpatients are in the hospital, outpatients are out in the community. They're ambulating around going to clinics. When I was in med school, it was very clear. Antibiotic overuse is a problem in the clinic. It's primary care docs and pediatricians prescribing left and right willy-nilly. Well, this is totally wrong. It's equal between hospitalized patients, who I usually see, and our colleagues in ambulatory medicine. And Dr. Lynch told you the answer to the last one. What fraction of courses of antibiotics, year after year, generation after generation, study after study, always the same result? What proportion are given appropriately, the right drug for the right dose, for the right indication? The old coin toss, 50%. We can do better. So this is how I would try to have you capsulize and crystallize and take this with you for the rest of your natural-born days, please. On the left, you have a slide which shows you the inexorable rise in multi-drug-resistant organisms. So this is what we see with MRSA, you've heard about, but also vancomycin-resistant enterococcus, fluoroquinolone-resistant Pseudomonas. Pick the bad bug. Over time, it's going up. And at the same exact time, we notice that the drug pipeline is shrinking. Year by year, we are approving and developing fewer and fewer antibiotics. So I think Al Gore is right in a lot of ways. I think he's right on the environment. I think there's an inconvenient truth with what we're doing to our planet, and there's an inconvenient truth with what we're doing to ourselves as well. So that's the analogy you're going to take forward. Over time, what are we doing with carbon emissions? They're going up and up over time, and at the exact same time, a shrinking pipeline of the fossil fuels we need to make those carbon emissions, right? This is the analogy. It's a human problem. No one's going to fix this except for ourselves. These are the brutal truths of antibiotic use. Antibiotic resistance is on the rise. This is our problem. They're ancient mechanisms of resistance, but we are driving it here today. And I would emphasize, too, that the discovery pipeline is essentially dried up. And unfortunately, we have to say that no one else is going to fix it. We have to control our own destiny. So as medical doctors, Brad and John and I, we hate this. I get that all the time. Are you happy about bad bugs? It gives you something to do. It's your career. I hate these guys, right? As doctors, we would rather do something totally different. And for you as the patients and potential patients in the audience, I know what you're thinking. What are you going to do about this? Because this is scary stuff. So there's different answers. I would emphasize it's not only the doctors who have a key role to play. Actually, I think there's a bunch of stakeholders involved, right? And I would suggest to you that our humble public servants, yes, the people you and I have elected to serve in Olympia and DC and everywhere in between, actually, I think they're the first people who we need to put pressure on to do the right thing. So, and I'm not a politician, I assure you, but I think they have a lot to do. So John Lynch showed you what's happening with respect to aureomycin and all of those antibiotics that are fed to animals because they get a little bit fatter and you can stuff them together and make more money by growing them on smaller square footage. This is crazy, right? We all know that that's wrong. Everyone, I would dare say, in the room can agree that this is a bad deal. Now, our friends in the European Union decided about 2 years ago that they were done. They were going to stop it. And with the stroke of a pen, if you're in the EU, you can't do that anymore. And I promise you, believe me, the cost of a hamburger in Belgium didn't go up by 100-fold. They actually survived this change, right? It turns out that people were happy to eat meat that wasn't fed full of antibiotics. Here in the United States, there are not one but two bills, one in the U.S. House, one in the U.S. Senate. According to an independent website called govtrack.us, check it out, these bills have, and I'm not exaggerating, 0% of passing in either the House or the Senate. Zero. Welcome to the new reality of your public servants. So a friend and I, Dave Raymanovsky, who's a hospitalist at Northwest Hospital, part of our UW Medicine family, and I recently wrote this op-ed piece in the Seattle Times. We've decided we don't even want to wait for the politicians. We just want to bring this to the general public. If you ate a piece of meat, or you're at the store and you have one that says there's no antibiotics in this meat, and this piece of meat has tetracycline and penicillin and on, which one would you choose? We think that meat should be labeled with all the antibiotics that are in it, and as consumers, we will drive this process forward. I would emphasize that we do have some good work coming out of DC. The Alliance for the Prudent Use of Antibiotics, APUA, our ID Society of America, IDSA, they got together back in 2010 and said, we're done. We need to have a national effort to bring 10 new antibiotics onto the market by 2020, 10 by 20. And in fact, one of the ways that they're doing this is to try to incentivize industry to do this work. Like Dr. Lynch said, drug industry doesn't want to do this because they can't make a lot of money so doing. So what we've done in DC is to create this act called GAIN. GAIN stands for Generate Antibiotic Incentives Now. And GAIN is now the law of the land. What it does is it gives these companies that do that work, it's about $1 billion in about 10 years to make a new drug. When they do that, they get more time with their patents. They can actually make more money through their intellectual property by getting a special dispensation. Today, there's one antibiotic that I know of called Tedezolid, and it is being developed for MRSA infections under the aegis of GAIN. So this is actually the law of the land today. That's a win for the home team. I would emphasize that our friends in DC really have to do this. Our National Institutes of Health, staffed by the smartest doctors in the world, and what they do is decide how to fund research coast to coast and planet-wide. The NIH controls a lot of dollars, but only those dollars that the federal government gives them. So when the budget is on the line for the NIH, and it feels like every other week we're in some kind of crazy budget crisis, these are the guys who are really sweating bullets because doctors here at UW Medicine and across the country are waiting for those grants to come across to keep this new research going. So there are other stakeholders as well. What about the researchers? If we give them our tax dollars, what will they do with them? So we need to incentivize research into this area. The good news about this problem is that everyone agrees it's a problem, and that means that there's a lot of interest and work in this region. So that means new drugs, to be sure, we desperately need them, but it's more than that. We need to think outside the box a little bit as well, beyond drugs. What am I talking about? So probiotics, we need to talk about probiotics. Our friend and counterpart at Children's is Dr. Scott Weissman, wonderful ID specialist. And he said to us recently, you know, I'm sick of it. I'm sick of being anti-everything. Antibiotic, antimicrobial stewardship, anti-overuse. I want to be for something. Let's be probiotic. Let's become the champions of normal flora or the normal microbiota. He's darn right. So there actually is some science behind this. Case in point, Lactobacillus crispatus. Think back to the green columns that Dr. Cookson showed you in one of his last slides, swabs taken from the vaginal tracts of healthy women. What it turns out we get, if we do a test of these areas, here in this corner what you see is a healthy appearing human cell, and stuck to that cell are those little blue lines. The blue lines are a bacteria called lactobacillus. In fact, if it comes from a human reproductive tract, it's probably Lactobacillus crispatus, or Lactobacillus inners, or Lactobacillus jenseni. These are human lactobacilli. They are so important for the normal function of human reproductive tract in women because they make hydrogen peroxide and other factors too that Brad could tell me about. But basically, they make acid that drops the pH of that milieu. Super important because where there's a low pH, E. coli won't take up shop. Now, as many of the people in the audience know, urinary tract infections in women are almost always E. coli, almost always. How does this happen? I've got a cold, I go to see the doctor, they're tired or exhausted or quarreling with their family, and they do the unthinkable. They give me amoxicillin for something that's clearly viral. Well, that's a bad idea because not only does it not fix my sinuses, but it will nuke my vaginal flora, and what you can end up with are patients who have removal of these healthy bugs, replacement with E. coli, and that leads to UTI. So why don't we just put back a probiotic, the normal lactobacilli? You can go to any supermarket or health food store tonight and get lactobacillus over the shelf. That's Lactobacillus rhamnosus, Lactobacillus GG. That's lactobacillus from the rumen of a cow. And as my wonderful colleague, Jeannie Marazzo, says, women do not want cow manure in their vaginas. And I can only trust and hope that she's right. Those lactobacilli have not evolved to make H2O2. They don't make hydrogen peroxide. They don't do this. But we have done work here at UW Medicine under the auspices of Dr. Ann Stapleton, looking at women who on upper campus and in the community have recurrent UTI because of E. coli. They either got a placebo, meaning a dummy, or they got the actual Lactobacillus crispatus. And when it was given as a suppository in a very simple regimen, the risk, the so-called relative risk of recurrent UTI in those patients was cut in half. That's a relative risk of 0.5. Even more intriguing, those women also had a much lower chance of being colonized of their vaginal area with E. coli, meaning their future risk, even beyond the study, was probably less. Very, very exciting. The numbers are small. The company that makes this is looking for investors to try to fund a phase 3 trial and take it forward and make this clinically available to all of you. Very exciting. What about vaccines? So vaccinations. Remember, a watchword of ID. Vaccinations are good. More vaccinations are better. I love immunizations. We have just done, there's probably more, I guess the only thing that's better for public health is public sanitation and clean running water when you turn the tap. After that, immunizations have done more to save lives than anything else we could ever do with antibiotics. Why don't we do this for these big bad bugs? Maybe we could. But as we've talked about, a lot of these are not strange germs. They're regular germs that have picked up a bad habit. They become antibiotic resistant, and that's really tough for our immunologists to target as a target for a vaccine. I don't want a vaccine for E. coli because it might keep my UTI away, but I need E. coli because it's helping me digest my dinner from just a few minutes ago, so I can't live without it. But there are some germs that I really would be happy to live without. Actually, Staph aureus is probably one of those. MRSA, I hate that stuff, and it's actually something that kills and maims our patients, makes them sick. I'd love to have an MRSA vaccine. This is one example of some investigators in Chicago who've been working on exactly that. What they did was to create a vaccine against a small number of staph strains. Then they put staph into the lungs of mice, let the pneumonia develop or not, sacrificed the mice, and looked at their organs. And what happened, as you can see on the on the left side of your screen, that's a micrograph of the lungs of these mice. I got to tell you, folks, you don't have to be a medical student to know that looks like a liver, not a lung. This is, and here on the micrograph, this is a lung that is chock-a-block full of pus and microorganisms, and the mouse didn't survive. On the other side, this is a vaccine recipient mouse, and the lung maintained a lot of its architecture. In fact, if we look at these mice over time, the ones in this Kaplan-Meier curve who got the vaccine were much more likely to survive. The ones who got the placebo were more likely to die. At least the ones who got vaccines for 2 out of these 3 strains, there is this problematic issue of this other strain on the right-hand side where there was no difference. That's part of the problem, isn't it? Vaccines are so specific to strains that are different from each other. They're not exactly subspecies, but it's kind of like that. And we need a vaccine that would go against all of these subspecies. That is really difficult work to do. In this particular study, they only looked in the lung. They didn't look, for example, at skin and soft tissue infection. They didn't look at bloodstream infection. I think there's tremendous potential here, but I have to say I'm also worried about unintended consequences. Maybe if I lose my Staph aureus, I'll end up with more yeast infections on my skin. We simply don't know for sure. The road to perdition is littered with good intentions, clearly an area of ongoing active research. I think that brings it back to me, doesn't it? I'm a medical doctor. What is my role as a key stakeholder here? So it turns out that giving antibiotics is actually a little bit complex. When I was a medical student, it was not complex. It was very easy. If the patient is not very sick, give them something light. If they're super sick, give them gorillacillin and then hope for the best. And that's clearly the wrong way to go. We still give gorillacillin for the super sick patients, but we need to be able to use Dr. Cookson's diagnostics and then de-escalate, focus our treatment. Otherwise, we drive resistance up. Now, everybody knows that's true in all these other industries. You hop on a commercial flight, you have to trust that the person at the stick knows what they're doing. This is a picture of the flight deck of a commercial airliner. And you have to know and trust that the guy in the left seat and the right seat know what they're doing and that they've had a little time to get trained. Oh, this is my son in the left seat, and he's ready to hit the throttle. He's ready to go. He's not quite authorized. I promise you, we were still parked and hadn't yet taken off there. So the point is, we need to support our medical students and teach them the right way to learn about antibiotics. So I recently participated in this nice study where we interviewed our graduating medical students, University of Washington, Johns Hopkins University, and Miami, and asked them a series of questions about antibiotics, and the results were quite striking. These are 4th-year medical students who were just essentially becoming MDs. How do you like your training on antibiotics? Was it either good or very good? About half of people said yes. The other half said it was not good or it was really not good. That's not good. We asked them some very basic questions about infectious disease case scenarios. They got about half of these correct, and they weren't super duper hard case questions, I promise. We asked them how they were getting information about antibiotics, and they didn't know how to get that information. Some were going online, some were using web apps, some were reading a textbook, some were going to Wikipedia. Don't go to Wikipedia, okay? We even asked them, have you ever heard of our career, antimicrobial stewardship? Fewer than half had even heard the term. We can do better. And I want to emphasize that the medical students at this university are absolutely top flight. I've been teaching them here for more than 10 years. They can compare to anyone coast to coast, like Johns Hopkins, like Miami. This is a national phenomenon. It's a failure of us as educators, certainly not of our trainees. It's pretty clear that we could do better. So what do we need to do to fix this up? So our career, it's called antimicrobial stewardship, right? We didn't used to call it that. Initially, it was called antibiotic control. And I got to tell you, doctors don't like being controlled, so we had to run away from that term. Then we came up with antimicrobial management. But back in the go-go 90s, we had this experiment called HMOs, healthcare management organizations, and this had sort of a big dark cloud over it, although in some ways it was great. So we changed it to antimicrobial stewardship, because nobody knows what a steward is. It sounds kind of medieval, you know. It's clearly somebody who's not going to come and control or manage you, right? What are they? So stewards by definition are a person whose responsibility is to take care of something, right? And it actually is a really nice term, isn't it? So we've been talking to you about the global perspective around stewardship. Stewards are here to take care of anything. You're in Seattle, you're all environmentally aware. You're trying to be good environmental stewards, and I bet you're doing a great job. If you are finishing up with a piece of plastic or something, you're going to recycle it, right? You're not going to chuck it in a landfill. It's the same concept with respect to environmental stewardship. The problem is that it takes a culture change to make that happen, doesn't it? It's a behavioral change for you to learn how to recycle your food. Think back to 10, 20 years ago. Recycling stations didn't even exist. There's an infrastructure, there's a behavioral piece. The same is true with respect to antibiotics. It's all about your perspective. So I took this picture at the trailhead for Silver Peak. It says, please be aware, hunting season's open. And somebody wrote in Sharpie, so's hiking season, don't shoot us. For the record, I'm a hiker, not a hunter. One landscape, two agendas, the possibility of a calamitous intersection, right? Two different ways of looking at the world. This is what happens in clinical medicine. Because doctors at this medical center and coast to coast, when they come to work every day, they have a global perspective. They want to be good world citizens. But the reality is they can't worry about that because they don't live in the world. They live in Seattle, they're working at this hospital, and in fact, they can't even worry about the hospital because right in front of them is this one super sick patient on the ventilator. They're in septic shock, they have an infection, we don't know what it is because Brad hasn't given us the answer yet. For God's sakes, I can't let this person die on my shift. I better give them the biggest, baddest stuff I got. We call this the cycle of spiraling empiricism, and it's pretty straightforward. We don't have a diagnosis. If we don't have a diagnosis, we better cover these patients broadly. And when we cover these patients broadly, we will select for those multiply drug-resistant organisms, the MDROs. Once we do that, the horse is out of the barn, the cat's out of the bag, whatever animal farm euphemism you want to use. And those MDROs do go from person to person. They will set up HAIs, hospital-acquired infections. By the time this doctor comes on shift next, they'll say, I don't know what this next patient has, but boy, I've been seeing a lot of those MDRO HAIs. I better cover them broadly. And the cycle becomes a very, very destructive one indeed. So what do we do in response? CDC, smart people, they have come up with a wonderful curriculum and in fact a series of protocols to help us make these correct decisions. The four parts of the puzzle are to prevent infections, diagnose and treat them, prevent their transmission, and then to use antimicrobials wisely. That's our little piece of the puzzle. But of course, because those four pieces of the puzzle were a little too simple, they thought they'd give us some more detail. I am not exaggerating. Ladies and gentlemen, it is a 12-step plan. And the first step is not admitting that you're addicted to antibiotics and you're powerless over your addiction, although it probably should be, come to think of it. Vaccinate them, get the catheters out, target the pathogens, this sort of stepwise pattern, which is what we have adapted in our practice on a daily basis, not only for medical students, but for our medicine residents and our colleagues who are attendings in internal medicine, surgical specialties, etc. These are the concepts of what we go through with our doctors all the time. The problem with this is it's kind of dry, right? So we have come up over time with some more memorable tricks that will stick in the minds of the trainees. And they're generally sort of analogies. So here's one of the analogies, right? On the left is what Detroit's been telling us for years we're supposed to have, but on the right is, at least in Seattle, what you're often going to reach for, right? It's cheaper. It can go some places the other guy can't. It's good for the environment. You actually stay fit when you do it. as long as you don't get hit by somebody driving the thing on the left. And so, you know, to be very clear, sometimes I will need what you see on the left, right? If my kids have a soccer match on top of Mount Olympus or hail machine gun fire, I'm going to take the thing on the left. Usually for my daily commute, the guy on the right is fine. And so we can use this as an analogy for antibiotics. For treatment of MRSA infections in the skin and soft tissue, we've got this guy on the left, an antibiotic called linezolid. It's good stuff, except that it poisons you. It's actually quite effective. It costs $100 a pill, and it's a twice-a-day pill, and it takes 10 days to treat. The guy on the right, trimethoprim sulfa, the oldest antimicrobial still in use, costs a few pennies a pill and equally effective in most cases. So this rings home with our trainees. Here's another thing. I like to give people mnemonics. So regardless of which of these you're dealing with, VAP is vent-associated pneumonia, CABC is cath-associated bloodstream infection, CAUTI is cath-associated UTI. What do they all have in common? Tubes, right? Plastic where plastic doesn't belong. These are helpful pieces of plastic. So I came up with my little axiom, time plus tube equals trouble. Anytime we put catheters into these patients, and any body cavity you can describe, we've got a catheter for that. So any catheter you can imagine, we need to get those catheters out. A breach in the normal mucous membranes or skin of the patient is a portal of entry for infection in these patients. We try to show our doctors the implications of what they do on a daily basis. So here are culture plates taken from a laboratory, a clinical microbiology laboratory, although not in this building, but a wonderful first-rate clinical micro lab. And the enter key and the space bar were swabbed with a moistened swab, and that was plated out on a piece of agar. And as you can see, essentially they are completely sterile. There's a little coag-negative staph. You get those things on the left just breathing the air, touching a doorknob. If you go several flights up in this particular hospital to the ICU and swab the enter key and the space bar, it looks a little bit different, doesn't it? So we can show them the culture plates and say, you darn well will clean your hands before and after every patient encounter, because in our hospital we have the potential for these bad germs. As long as your hands are clean, everything's going to be fine with that patient. Professor Semmelweis came up with this idea when observing what was happening on an obstetrics ward in Austria many years ago, and in his honor, we still do this every time. It's a success. This is a success. When I was a medical student, washing your hands before and after a patient was a strange thought. We had sinks, but we didn't even really use them. Today, if I have a rate of hand hygiene compliance below 98% on any unit, that's a big, hairy deal. It is part of the culture of our patient care at UW Medicine, and that's true nationwide as well. These issues of HAIs have dramatically gone down over time. We're trying to give doctors the best information we can over time regarding electronic information. Occam is the online clinical care alerts and messages, the brainchild of Dr. Eric Van Eaton, one of our critical care surgeons. All of our protocols, all the information that people could want at their fingertips, and if you scan the QR box, it's on your smartphone. Yes, antibiotics, there's an app for that. And on the app, you'll see antibiotic resistance profiles. We give information about how to dose antibiotics for people with kidney disease, step-by-step instructions with doses for every infectious syndrome that you could think of. So I think that the final piece before I conclude, and we'll open up to questions, relates to this, which is you, the potential as patients. What is your role? What can you do to combat resistance? If you're not angry or at least PO'd, then you have been paying attention, right? So this is your question. What can I do to make a difference? There's all kinds of stuff. So I want you to bring resistance under control, because each and every one of you is going to become, as of tonight, yes, an antimicrobial steward. And here's how we do it. If you don't smoke, congratulations. If you do, tonight's your night. Tonight is your night. And congratulations, the first day of the rest of your life. When you smoke, you put to sleep all the natural defenses, the beast mode, whatever you want to call it, that lives in your lungs and keeps infections down. Smoking doesn't give you bacterial infections. It's the killing of your lungs that will let the bacteria come in. And even if you don't have a bacterial infection, if you smoke, you will cough, you will see a doctor. That doctor will have an urge to give you an antibiotic, whether you need it or not. For God's sakes, don't smoke. Number two, get your vaccines. Not vaccines for MDROs, vaccines for everything else. We don't have a lot of vaccines against multi-drug resistant organisms. We do have vaccines for flu, for pertussis, for the things that will give you a respiratory infection, to drive you to see your doctor, to give your doctor that diagnostic uncertainty, to drive unnecessary use of antibiotics. I know a lot of you haven't had your flu shot this year, and I forgive you. Next year I won't be so forgiving, because now you know that whether or not you've had the flu before, whether or not you've perceived you've had it, you can catch flu and then spread that to other people who can't combat that, and that can drive antibiotic use as well. What else is there to do? If you do get sick, for God's sakes, please stay home. We'll thank you for this. It's called respiratory hygiene. It's also called common courtesy. Being sick is rotten. Making somebody else sick, that should make you feel really rotten as well. I think that this all comes down to this concept of getting smart around antibiotics and knowing when they work. cdc.gov/getsmart. Check it out. Great resource for you to share with your friends who are non-believers, if you will. Cold or flu, antibiotics don't work for you. Antibiotics don't work for viruses. They won't make you feel better sooner, although you will have more Candida vaginitis and allergic reactions and on down the line. So I think the other key is to say, I want you to talk with your physicians about this. If you go to the doctor's office with a cold or flu, be willing to hear the idea that you have a bad viral infection and not necessarily something that antibiotics will treat. There is still a consumer idea. I'm sick, I paid you to take care of me, give me my pill. Boy, that's a bad model in so many cases, and I appreciate your willingness to hear the idea that ibuprofen and not antibiotics will do it. And finally, if anybody doubts whether your vote counts, I hear this on TV all the time, your vote really counts. Get educated about the people we're sending to DC. Do they believe in evolution? Do they have a scientific understanding? Will they fund the NIH, or is their entire mode of being to undercut the very government that they're now serving? So this is what the last slide of Dr. Lynch's show is the same as mine. It's our giant throbbing brains. All we have is our creativity, our engineering, and our ability to adapt and change our behavior. This is a behavioral problem. So there are very few new antibiotics coming. Resistance is our issue. We have to fix it. Have a global perspective, but also understand that your own decisions have a tremendous impact. Together we can do it. In fact, we have to. A world without antibiotics is not one that I can conceive of. It is not acceptable. So I truly thank you for your time, and I'm sure we can all take your questions too.
And this is only our second night, you guys. So I'm looking at the correct clock, and we have some time for questions. So if people would like to come up to the microphones.
Yes, I was interested in your comment about probiotics preventing certain things, which I totally get. One of the things two items that are very commonly in use today for flu and colds are silicosum, how do you say that, and with zinc. And I'm wondering if you know anything about these. And I know a great many people who the minute they get the flu reach for silo, and some of us who get colds try to grab very early, both of these very early in the process. I don't even know what these are. And I'm wondering if they're the kind of thing that the body can develop resistance to, like antibiotics. Maybe that's a strange question because they're naturopathic remedies. And yet, Acilo has passed the clinical trials for use on flu. I kid you not. And I don't know on but it was a mainstream doctor and not a naturopath who told me about it. So I guess I'd like to get your comments on it and ask if they're a good alternative to antibiotics in the same sense that probiotics are, and if we can develop a resistance, or if the antibiotics if the flu and colds will develop a resistance to those.
So it's a great question. Cold and flu are viral infections, right? And viruses, they're not exactly alive, they're not exactly dead, they're these floating bags of genomic information, and they require the host to infect us. So they're big and bad, and they're a problem, and they're super duper common. We've all, my goodness, every one of you is either just getting over a cold, or I'm sorry to tell you, you're about to get one, right? So we know that's what happens in America in the wintertime. I'm a big proponent of doing something active about cold and flu. So the things that I know will work are to quit smoking, to have a healthy, nutritious lifestyle, to exercise, and to stay away from folks who are coughing and sneezing. And you do all those things, and so you are awesome, and I thank you for that. I don't know that a probiotic, meaning a microorganism that we could colonize our nose and sinuses with, would be of help there. I think that beyond that, it's not clear what else there is to do except to boost the immune system with vaccines, for example, against flu. With colds, the two homeopathic remedies you mentioned are not ones that I have familiarity with, so I can't comment on those. I will say that generally speaking, the thing that we should do around cold and flus is to be open to the idea that there might be remedies or some other natural product that could help. After all, the majority of antibiotics we use today are built on natural products too. But at the moment, I'm not clear there's anything else we can do along those lines. Are these useful in my view? I'd have to read about them. They're new to me. The things that I've looked at in the past, vitamin C, we see this all the time. Should I take an emergency? It's vitamin C, a great way to acidify your urine, and if you want to build kidney stones, you can take even more vitamin C. With respect to infections of the upper airway tract, it has never panned out, which is a shame, because I love vitamin C. It's easy to get, and aside from the acid reflux and the kidney stones, it's probably benign. But I've never come across anything like that. The only remedy that I know of that really does help with colds, not so much flu, is zinc. So there is a zinc lozenge that you can take, and this really does reduce the duration of symptoms of colds caused by rhinovirus, on average in big studies, by about a day and a half. And that's a day and a half back at work. So I like zinc. It gives you terrible nausea, it'll turn your tongue black, and you'll have constipation, but it works. And so that's something I've reached for before. Thank you. It's a good question.
So somewhat along similar lines, I've heard of instances where there's a lot of resistance in the GI tract, where they had some success with like a microbial transplant from a spouse.
Yeah.
I was wondering if there's been any progress on that front.
It's huge progress. You want to do this one?
Want me to do it? Or you want
Yeah.
Oops. I love, I'm still up here, yeah. This is great. Fantastic. I get to talk about stool. So, correct me if I'm wrong. I don't know, you disappeared. Did I make sure I asked this question right? So, remember I mentioned that disease C. difficile, Clostridium difficile, associated diarrhea? So the big problem there is a lot like that vaginal vaginosis, the bacterial vaginosis, where you get a dysbiosis. The bacteria in your gut that are good are sort of messed up by getting antibiotics. So it's really a two-step process. One, you got to get the C. diff in your gut. It's a pretty hardy organism. It can live as a spore, kind of like a seed, very resistant to cleaning. Get on people's hands. When people defecate, I'll tell you a little secret. When people have diarrhea, it's aerosolized. It floats around the room. Sorry. But it floats around, those little spores float, and they land everywhere, and then people touch them, and that's, again, why we need to wash our hands really well in healthcare settings especially. But you take it, so you get that, you get it in your gut. It can kind of live there. Some people actually colonize this. When you're a neonate, a lot of them have C. diff in there without causing disease. Then you get an antibiotic that kills off a lot of those good bacteria in there, right? And then that C. diff can grow and cause colitis, inflammation. It causes diarrhea. It can cause toxic megacolon where your gut gets enormous, like 10, 11, 12 centimeters. It can actually rupture and it can kill you. It's the #1 healthcare-associated infection in the United States right now. And we can give you an antibiotic for it. The common one's called metronidazole. It can make your toes numb and cause other problems, but it works pretty well. It makes everything taste like metal for 2 weeks. Makes you not want to eat, which is really terrible when you're having diarrhea. But the problem is that we can give you that. It doesn't fix the problem with the dysbiosis. And then a lot of people can get another course, and each time you get another round of it, the risk goes up and up and up. And by the time you're going through several courses of antibiotics for this problem, you're feeling pretty awful, you've lost a lot of weight, you're not eating anything, you're nauseated all the time, and your gut microbiota is a mess. It's totally destroyed. So actually going back 50 to 100 years, the veterinarians used to do a thing called transfaunation, where they take the feces from one animal and put it into another animal. You take one cow's stool and put it into another cow's stool. And this seemed to work with these sort of diarrheal illnesses. And so back in I think the 50s or 60s, a medical physician actually decided to try this on a human being, and it worked. They didn't know about C. diff. And back in over the past 10, 20, 30 years, individual physicians have started to use this technique, where they'll take stool, usually a spouse's stool, sometimes a nurse's stool in the clinic. In kind of the last 10 years, you take that stool, you put it in a special Cuisinart, put aside. Cuisinart it, strain it through a coffee filter, right? The special coffee filters. And then you drop a nasogastric tube in, and you squirt the filtrate down in there. And basically, what you're putting is the new microbiota from this person, a microbiota transplant, right, into the person's gut. And we can do this different ways now. We can actually do it by colonoscopy, a little bit more aesthetic, right? You can put an enema up there, and actually you can go on the internet and Google how to do this at home, because it's not that big a deal. And what's really fascinating, we have a physician here, Christina Surowitz, who's actually one of our associate deans, who's one of the world experts here at UW. She's world experts in this process is here at UW Medicine. She practices at Harborview. She does it by colonoscopy. What's really amazing about this is now it's been done in hundreds of people. There's no randomized control studies, but the success rate is in the high 90% range. And these are people who have had multiple bouts of C. difficile colitis and diarrhea. So they'll get it over and over, get all the antibiotics, get everything. And many of these cases have been reported, they'll drop the NG tube, they'll do the colonoscopy, give them the new stool, and within 24 hours they're having a normal bowel movement. And often for these folks for the first time in months, and sometimes even years. Really amazing. Now, what's interesting in Christina's studies, and when she looked at a review of all these, is gives us a little picture, though, of how important our microbiome is, our microbiota is. Now, we don't know this for sure, whether this is totally linked, but in the several hundred cases that she looked at, 4 or 5 of those folks who got their colitis cured developed new autoimmune diseases, or their old autoimmune diseases went away. The point there is that the microbiota probably plays a very important role in many things in your body. Not just with coagulation, not just C. difficile, but probably many other parts of it's the biggest immune organ in our gut. And so when we do these things, we're doing something pretty big. But for the time being, it's probably the best method we have for treating recurrent C. difficile right now. Now, one of the biggest issues, though, is that you've got to get a stool donor. And the stool donor process is expensive, and it's actually harder to become a stool donor than is a blood donor. And so it costs about $2,000 to get screened. Payers don't really want to pay for that very much these days, so that's in a process. And so a couple companies are actually looking at some very interesting processes, including one where they took the stool of a healthy 35-year-old woman, cultured up 65 bacteria, were able to isolate 35 where they got drug sensitivities, took those bacteria kind of all individually, grew them up, packaged them together in a little pill, and gave those pills to people. So basically had 35 different bacteria in there that they knew what they were. They were all susceptible to antibiotics that they needed to, and gave them to people. And in the 3 cases that have been published, all of them were cured. So I think that this idea of fecal microbiota transplantation is definitely a big process in the future. How it's going to be delivered, continuing with NG tubes and colonoscopies, certainly possible. Whether it's going to be pills that we buy, and give to patients in the hospital. But also the issue of probiotics as well. Sorry, more than you ever wanted to hear about stool, but there you go.
So,
as you can tell, I'm very excited by it.